Today we will be talking about a very important infection, that is torch infection, and the capital T in the torch stands for toxoplasmosis. So toxoplasmosis is caused by Toxoplasmosis gondii, which is an intracellular parasite, and outsist of the protozoan is excreted in feces of cats. Can be present in the contaminated soil, in the raw meat. Similarly, raw meat of the sheep, pigs, and rabbit. Unpasteurized milk is another important source, and unfiltered water has been implicated in some of the outbreaks. Talking about this in incubation periods of 7 days for postnatal infection, and it ranges from around 4 to 21 days. Uh, a, a tagline about the fetal infection is that the fetal infection rate is highest in third trimester, but fetal demise and fetal compromise is highest if infection is acquired in first trimester. Talking about the vertical transmission, so vertical transmission is usually transplacental hematogenous spread, and it's 25% in the first trimester, 75% in the second trimester, and 90% in the third trimester. During vaginal delivery, the transmission of the toxoplasmosis is also possible, and if a mother is infected, one of the clue will be lymphadenopathy, as it occurs on all adults. So it could be one of the clue in any patient presenting with lymphadenopathy in pregnancy should be screened for torch infections. Now, what happens if fetal infection occur in the first trimester? Most of the time, abortion and severe scenic infection, ophthalmologic sequelae is common. If it does occur in the second trimester, the classic triad that is of hydrocephalus, intracranial calcification, and choroidititis is seen if the infection occurs in the second trimester. Jaundice, hepatosplenomegaly, anemia, seizure, microcephaly, developmental delay in vision problems due to certain retinal changes. These are the common consequence of the infection that happens in the second trimester. For third trimester, usually most of the baby born with the mothers who have active infection in the third trimester have asymptomatic and they are asymptomatic birth. Now, this is one of the slides that I choose to actually talk about the trying hydrocephalus, and there is actually this area is not showing, but here's some calcification could be seen, and this is the retinal photograph which shows the choroidititis. Other symptom signs to actually make a list, it's a long list, but prematurity, IUGR, intrauterine growth restriction, fever, maculopapular rash, thrombocytopenia, myocarditis, and pneumonia could be other manifestation of the same congenitally acquired toxoplasmosis infection. Now, how we evaluate a newborn with possible congenital toxoplasmosis infection? So maternal serology and maternal history is very important. Then we look for the physical examination. We got a huge spleen or liver, hydrocephalus, or sometimes microcephaly. Fundal examination for choroidititis could be of clue. Similarly, neuroimaging, CT brain, MRI for hydrocephalus and intracranial calcification, and lumbar puncture may yield mononucleocytosis, and sometimes PCR could also be done for the toxoplasmosis. Similarly, serology, CBC, thrombocytopenia, and deranged eleptism may be other clue, which are common other clues. Actually, what is the serologic diagnostic criteria, which is here? But here, if you talk about the prenatal diagnosis, so once the diagnosis is confirmed, then we have to start the fetus on a surveillance, that is ultrasound every 2 weeks since diagnosis, and we could perform PCR on amniocentesis, and it is one of the best method for the diagnosis of fetal infection, and it has been implicated that almost 85% of sensitivity has been noted if amniocentesis is done between 17 to 21 weeks of gestation. Now, serologic diagnostic criteria is that IgM specific for Toxoplasmosis if it is positive for after 5 days of life, or IgA titer is after 10 days of life. Its diagnosis of a congenital toxoplasmosis in infants with positive titer of IgG for toxoplasmosis. Uh, the second criteria is the positive of toxoplasmosis IgG beyond 12 months. So one is IgM, IgA specific, and the second one is the IgG related. Third is positive PCR, and fourth is again about relating IgG titer in first year of life or increasing IgG titer compared to mother. So these are all four of them are diagnostic serologic criteria. Now, how we manage a case of congenital toxoplasmosis. So we start with 1 milligram per kg BD for 2 days. This is pyrimethamine, or we can say 2 milligram per kg per day. 1 milligram per kg. So for the ease, I have actually written 1 milligram per kg BD for 2 days. Then with the same dose, we OD for 6 months, and we continue the same dose for 3 days out of 7 in a week, and for next 6 months, and we prefer an alternate day regime. Some literature specifically mention that Monday, Wednesday, and Friday. So you give the patient pyrimethamine on these days for next 6 months. So total of 12-month duration is complete. And similarly, sulfadiazine, 50 milligram per kg per BD is given for 12 months, or it's actually 100 milligram per kg per day dose, or 50 milligram per kg in the BD dosage. We give folinic acid to counter the toxicity of pyrimethamine. Again, for the same day where pyrimethamine is used Monday, Wednesday, and Friday. So it's again for 12 months. The use of prednisolone or prednisone is 1 milligram per kg or 0.5 milligram per kg BD if the CEC protein is greater than 1000 milligram or 1 gram per DL, or severe choroidititis is seen on fundoscopy. Then we continue it until either the severe choroidititis is resolved or the CEC protein is less than 1 gram for DL. Then later on we taper on the dosage. Prenatal, if spiramycin is used if fetal infection is uncertain, and it can be used in any trimester. 1 gram TDS per oral to the mother is the dose. Pyrimethamine and sulfadiazine and folinic acid, all three can be used for a second or third trimester. If fetal infection is certain or probable, then the dosage is almost similar to that as shown earlier, but but there's a difference here because this sulfadiazine is going to the mother. So 50 milligram BD for 2 days and once daily for once daily from third day, and sulfadiazine is equally 1.5 to 2 gram per oral BD, and folinic acid or glucuronine is given from 5 to 10 milligram daily. Similarly, sulfadiazine alone can be used because pyrimethamine is too toxic to be used in first trimester if the fetal and toxoplasmosis is certain and probable. Signing out, Abdul Ahad, pediatric resident.